Welcome to the deep dive. Now, if you're a GP trainee knee-deep in AKT prep, you'll know musculoskeletal stuff.
Well, it's not simple, is it? It's more like navigating a maze, really. Lots of red flags, tricky drug interactions, and those subtle symptoms that could mean something, systemic.
That's a perfect way to put it. And our goal today isn't just a quick overview. We're really aiming for a high-yield deep dive, pulling out those essential diagnostic clues, those management thresholds you absolutely need for safe practice and, frankly, for the exam.
Exactly. We want the facts you can grab hold of under pressure.
Mm-hmm.
Okay, let's get into it. We'll be moving at a decent pace, but focusing hard on the details, the criteria that really matter day to day. Starting with, well, the big one, rheumatoid arthritis.
Yeah, RA, definitely a cornerstone. So in primary care, the first hurdle is spotting persistent synovitis. We're talking actual swelling, tenderness, especially in those small joints, hands, feet. It looks different from OA nodules, doesn't it? Absolutely. And the key action point here, the sources are really clear on this urgent referral. That's for any suspected persistent synovitis. Even if the initial bloods, the ESR, CRP, even rheumatoid factor come back normal, you still refer urgently.
You absolutely have to. Waiting is just not an option because delay means, well, irreversible joint damage. Now, once the patient gets to rheumatology, they'll look beyond just RF. Anti-CCP antibodies are really important.
Diagnostic and prognostic, right?
Exactly. And the fascinating thing is anti-CCP can show up years before symptoms even start. It sort of points to that underlying immune problem simmering away long before the joints get inflamed.
So if you, as a GP, happen to see a positive anti-CCP, maybe on a screening test for something else, even with mild symptoms, that should really ramp up the urgency.
Definitely. It's a significant flag. And then thinking about imaging, if the disease is established, what are those classic X-ray findings we should have in mind?
You're looking for damage, aren't you? Erosions.
Yep, erosions are key. Loss of joint space, definitely. And that soft tissue swelling you might see around the joints. But, diagnosis and particularly management in RA, it really hinges on working out the risk, doesn't it?
Yeah.
Stratifying who's likely to do badly.
Which brings us to those markers for poor prognosis. This is vital for knowing how closely to monitor or when to push for escalation. What are the specific things that tell us, okay, this person's disease might be more aggressive?
There's a fairly well-defined list. Genetically, HLA-DR4 is a known risk factor. Serologically, being positive for anti-CCP, especially high levels, points to a worse outcome.
Okay.
Then seeing early erosions on an X-ray is a bad sign. And interestingly, a very slow, insidious onset where it creeps up over months that often predicts a tougher course compared to a sudden flare-up.
That feels a bit counterintuitive, the slow onset being worse.
It does, but the thinking is the disease has been silently establishing itself, getting entrenched before it becomes really obvious.
Yeah.
Other things are extra-articular features like rheumatoid nodules and having other significant health problems, multimorbidity.
Right, that makes sense. The slower it comes on, the more damage might have happened under the radar. Okay, shifting to management. First, symptom control, then hitting the disease process itself.
Yeah, symptom control is usually NSAIDs, maybe simple painkillers. But the crucial part is starting DMARD's disease-modifying anti-rheumatic drugs really quickly. Standard practice now is often combination therapy, like methotrexate plus another one, maybe sulfasalazine or hydroxychloroquine.
And often with a steroid bridge initially.
Exactly, a short course of glucocorticoids to dampen down the inflammation while you wait for the DMARDs to kick in, which can take, weeks or even a couple of months.
And then the next level up, biologics, like TNF inhibitors. That's firmly specialist territory, but GPs have a really important safety role, don't they? Especially around starting them.
Absolutely critical. This is a major safety point for the AKT too. Before anyone starts a biologic, they must be screened for latent TB and hepatitis B and C.
Because these drugs are immunosuppressants.
Right. They significantly increase the risk of reactivating these infections, which can be really serious, even life-threatening. And often, coordinating that screening falls to primary care or the hospital's pre-assessment team.
And even for the standard DMARDs methotrexate, leflunomide, sulfasalazine, ongoing monitoring is non-negotiable once they're started.
Completely. You've got potential liver toxicity, potential bone marrow suppression.
Yeah.
So regular blood tests are essential. For all three, you need periodic FBC for blood counts, LFTs for liver function, and UNEs for kidney function. The exact timing varies, but it's a continuous safety requirement.
Okay, that focus on safety and monitoring leads us straight into another high-yield, high-risk area. The specific side effects of these rheumatology drugs, there are quite a few to get straight.
Yeah, this list can feel a bit overwhelming, but knowing the key associations is so important. Let's break it down by system. Let me start with the eyes. Ocular toxicity causes a lot of patient anxiety.
Right. So if a patient on room meds reports visual changes, what drugs jump to mind?
Okay, the big one is hydroxychloroquine. It's known for causing potentially irreversible retinopathy. That's why regular eye checks are mandatory.
Okay, hydroxychloroquine retinopathy.
Yes, and then both hydroxychloroquine and the older drug chloroquine can cause corneal opacities, but those are usually reversible if you stop the drug. And don't forget, prednisolone, long-term steroids, are a common cause of cataracts. So you need to differentiate. Retinopathy is the main hydroxychloroquine worry.
Got it. Moving to the lungs, what's the classic pulmonary issue with methotrexate?
Methotrexate can cause pneumonitis, which can sometimes progress to fibrosis. It's often an idiosyncratic reaction, not strictly dose-related, but it's serious and means stopping the drug immediately.
Is methotrexate the only culprit for lung problems?
No, you can also get interstitial lung disease, ILD, with sulfasalazine, and importantly, leflunomide.
Ah, yes, leflunomide. And that one has other specific monitoring needs besides the lungs and the usual bloods, doesn't it?
It does. Leflunomide is a bit unique. Besides watching for ILD and doing the FBCLF keys, you also need to monitor blood pressure routinely, as hypertension is a known side effect. And keep a close eye on those LFTs for hepatotoxicity.
Okay. Let's cover off the kidney and some other sort of miscellaneous side effects.
Sure, for kidney damage, think about the older drugs like gold salts and penicillamine. They were known causes of glomerulonephritis. Not used so much now, but still turn up in exams.
Right.
Then sulfasalazine, often used in IBD, and seronegative arthritis too can cause infertility, particularly in men. Thankfully, it's usually reversible if you stop the drug. And penicillamine has that very specific, rare risk of worsening myasthenia gravis. These details just show how systemic these drugs can be.
Definitely highlights the need for vigilance. Okay, let's switch inflammatory gears to gout, super common in primary care. The presentation can be classic, that agonizingly painful big toe joint. But there's a common diagnostic trap, isn't there, with the uric acid level?
Oh, absolutely. The biggest pitfall is checking the serum uric acid during the acute attack. It can be falsely normal or even low,
Why is that?
because the uric acid has effectively dumped out of the bloodstream and into the joint, causing the inflammation. So the rule is, if you suspect gout, you must repeat the uric acid test at least 2 weeks after the flare has completely settled down to see what their baseline level actually is.
Right, crucial timing point. And what if you're worried it's not gout, but septic arthritis? That's the red flag here.
Yeah, if septic arthritis is on your differential diagnosis, you have to aspirate the joint. That's the gold standard. Get some fluid out.
And what confirms gout in the fluid?
You're looking for monosodium urate crystals. Under polarized light microscopy, they classically look like needles and show negative birefringence. Seeing those crystals confirms gout and rules out infection or other crystal problems like pseudogout.
It's also interesting how often other factors trigger a gout attack. What are the common culprits we should be advising patients about? Things that make it worse?
Yeah, patient education is really key for prevention here. Common triggers include thiazide diuretics, very common cause, cyclosporin 2, lifestyle factors like excess alcohol,
Right.
certain drugs like parzinamide for TB, cytotoxic chemotherapy drugs, and surprisingly to many, low-dose aspirin can actually impair uric acid excretion and trigger an attack.
Good list to keep in mind for counseling. Okay, patient presents with an acute flare. What's the management ladder?
Step 1 is usually a high-dose NSAID, gives quick relief. But importantly, always co-prescribe a PPI, a proton pump inhibitor, for gastric protection, especially if they're older or have risk factors.
Makes sense. And if NSAIDs are out, maybe kidney problems or peptic ulcer history?
Then step 2 is colchicine. It works differently, targets neutrophils, but it has significant GI side effects like diarrhea. And you absolutely cannot use it if their kidney function is very poor, specifically a creatinine clearance below 10 millimina. Big toxicity risk there.
And very important note, colchicine is not for treating high uric acid if there are no symptoms.
Absolutely not. Never for asymptomatic hyperuricemia.
Okay, so if NSAIDs and colchicine are both contraindicated,
Then you'd go for a short course of oral prednisolone. Or, if it's just one easily accessible large joint, an intra-articular steroid injection can work really well very quickly.
right. So once the acute flare settles, we think about long-term prevention with urate-lowering therapy, ULT. Who actually needs to start allopurinol?
The guidance is pretty clear now. Offer ULT if someone's had 2 or more attacks in a year, or even after one attack if they have complications like tochardy, those visible urate deposits, or a history of kidney stones, or if they already have chronic kidney disease, CKD stage 3 or worse.
And the timing for starting it, another potential trap.
Yes, definitely don't start allopurinol during the acute flare. It can actually make it worse by mobilizing uric acid. You wait until the attack is fully resolved, usually about 2 to 4 weeks after.
Okay. And what's the treatment target?
You start low and titrate the dose up, aiming to get the serum urate level consistently below 360 micromoles per liter. That's the target to prevent future attacks.
And if someone can't tolerate allopurinol, what's the alternative?
The main alternative is febuxostat. It's another xanthine oxidase inhibitor. Works similarly. But there's a note of caution with febuxostat in patients who have significant pre-existing cardiovascular disease. So it's not always a straight swap.
Good point. Okay, let's move on now to the seronegative conditions. They're grouped because they tend to lack RF and anti-CCP and often linked to the HLA-B27 gene, right? And they affect the body differently from RA.
Exactly. They often target the spine, the axial skeleton, or where tendons and ligaments attach to bone, which is called enthesitis. Let's start with psoriatic arthropathy, PSA.
What are the key features to look for that distinguish PSA from RA?
Well, you've got the skin psoriasis connection, obviously, though not always present at the same time as the arthritis. But specific joint signs include dactylitis, that classic sausage finger look where the whole digit swells up.
Okay.
Serologically, it's negative for RF and anti-CCP. And on X-ray, if it's advanced, you might see that characteristic pencil and cup deformity. Looks just like it sounds.
And management often follows RA principles. DMARDs, maybe biologics if it's severe.
Broadly, yes, especially for peripheral joint involvement. DMARDs like methotrexate are used, and biologics are very effective, particularly if the spine is involved or the disease is aggressive. Now, next up, ankylosing spondylitis, AS. This one has a pretty typical patient profile.
Yeah, usually a young man, isn't it? Presenting with back pain, but a specific type of back pain.
Exactly, it's inflammatory back pain. Key features are morning stiffness lasting over 30 minutes, pain that actually gets better with exercise and worse with rest, the opposite of mechanical back pain, and often pain at night that wakes them up, usually in the second half of the night.
And AS isn't just about the spine, it's systemic. What are those important associated features we need to ask about?
Right, it's strongly linked to HLA-B27. Extraskeletal features are high yield for exams, acute anterior uveitis, that painful red eye with light sensitivity, also inflammation at tendon insertions like Achilles tendonitis, and less commonly, but seriously, cardiac problems like aortic regurgitation.
So, given it primarily affects the spine, management is less about drugs initially and more about movement.
Absolutely. The cornerstone is keeping mobile. Regular, vigorous exercises, key swimming is often recommended. NSAIDs help manage the pain and stiffness, and intensive physiotherapy is vital. Unlike RA, standard DRs generally don't work well for the spinal symptoms of AS, though they might be used if there's peripheral arthritis. Biologics are reserved for severe active axial disease.
Okay. Then there's reactive arthritis. The mnemonic is catchy, but what actually happens?
Yeah, the can't see, can't pee, can't climb a tree. Triad conjunctivitis, uveitis, urethritis, and arthritis is memorable. It typically follows an infection, usually gastrointestinal like salmonella or shigella, or a genitourinary infection, often chlamydia.
Are there any skin signs to look out for?
Yes, you might see circinate balanitis, which are painless, shallow ulcers on the penis, or keratoderma blennorrhagica, waxy, yellowish skin lesions, often on the soles of the feet or palms, looking a bit like psoriasis.
Now, if you treat the underlying infection, say the chlamydia, with antibiotics, does that cure the arthritis?
No, and that's a really important point. You treat the infection, of course. But the arthritis itself isn't an active infection. It's an autoimmune reaction triggered by the infection. So antibiotics don't shorten the arthritis course.
How long does it usually last then?
It's generally self-limiting, typically resolving over maybe 3 to 12 months. Management is mainly symptomatic relief with NSAIDs. Only in rare, persistent cases would a specialist consider DONs.
Right. Let's pivot now to a pair of conditions where prompt recognition is absolutely critical because of the potential for serious, irreversible damage. Polymyalgia rheumatica, PMR, and giant cell arteritis, GCA.
Yes, this differential is a classic high-stakes scenario because GCA is a true medical emergency. Let's start with PMR. Usually affects people over 50. The key symptoms are symmetrical aching and significant stiffness, especially in the mornings, around the shoulders and hips, the girdles.
And the blood tests.
You'll typically see markedly raised inflammatory markers like ESR or CRP. But crucially, The creatine kinase, CK level, is normal. This helps distinguish it from muscle diseases like
And
polymyositis.
the treatment for PMR?
It responds dramatically well to low-dose steroids.
Oh,
Typically start with prednisolone 15 milligrams daily. The response is often so quick it can be almost diagnostic.
okay. Now, GCA. Also over 50s, but the symptoms demand immediate aggressive action. What are the red flags for GCA?
GCA presents differently. Look for a new onset headache, often temporal, but can be anywhere. Scalp tenderness is common. Patients might say it hurts to brush their hair. Jaw claudication pain in the jaw muscles when chewing is quite specific. But the absolute major red flag is any visual disturbance.
Like amaurosis fugax, transient vision loss.
Exactly. Even if it was just for a few seconds and resolved. Any sudden visual change, blurring, double vision, or loss of vision in someone with suspected GCA is an emergency.
And the management threshold is immediate.
Absolutely immediate. If there are any visual symptoms or you strongly suspect them, the patient needs high-dose steroids right away. Either IV methylprednisolone or high-dose oral prednisolone, like 60 milligram plus same-day urgent referral to ophthalmology or rheumatology. You do not wait for a biopsy result if vision is threatened.
And if they have typical GCA symptoms like headache and jaw claudication, but no visual problems.
You still start high-dose oral prednisolone immediately, typically 40 to 60 milligrams daily, and arrange for urgent specialist assessment, usually including a temporal artery biopsy or ultrasound, to confirm the diagnosis. The steroids are primarily to prevent blindness.
Got it. High stakes indeed. Let's broaden out now to the systemic connective tissue diseases. Systemic lupus erythematosus, SLE, first. It's known for affecting multiple systems.
Yeah, SLE is the classic multi-system autoimmune disease. Clinically, you're looking for a constellation of features, things like a photosensitive rash. The classic butterfly rash across the cheeks is common. Non-erosive arthritis, often in the hands. Profound fatigue is almost universal.
What about organ involvement?
You can get inflammation of the linings of the lungs or heart pleuritis or pericarditis. Kidney involvement is common and serious, often presenting as proteinuria or nephritis. And neuropsychiatric symptoms can occur, like seizures, psychosis, or cognitive issues, lupus fog.
And the key blood tests for SLE?
The main screening test is the ANA, anti-nuclear antibody, which is very sensitive but not specific. More specific antibodies are anti-dsDNA and anti-SISM. Anti-dsDNA levels can fluctuate with disease activity, particularly kidney involvement, so they're useful for monitoring.
And complement levels.
Right. During active disease flares, complement proteins, C3 and C4, often get consumed in the inflammatory process, so you'll find low levels in the blood.
Okay. Next, systemic sclerosis, often called scleroderma. We need to distinguish the two main types, limited and diffuse.
Exactly. The distinction is mainly based on the pattern of skin thickening. The limited type, which used to be called CREST syndrome, mainly affects the skin of the fingers, hands, face, and lower arms, legs.
CREST stands for?
Calcinosis, calcium deposits under the skin. Raynaud's phenomenon, often the first symptom. Esophageal dysmotility, causing reflux swallowing problems. Sclerodactyly, tightening of the skin on the fingers. And cholangiocytaceous, small, dilated blood vessels. The antibody strongly associated with limited scleroderma is the anti-centromere antibody.
And the diffuse type. That one tends to be more severe with more internal organ risk.
Yes, diffuse scleroderma involves more widespread skin thickening, often including the trunk and upper arms, legs. And critically, it has a higher risk of early and significant involvement of internal organs like the lungs, interstitial lung disease, heart, and kidneys.
What are the antibodies associated with the diffuse type?
The main ones are anti-CLL70, also called anti-topoisomerase I, and anti-RNA polymerase III. The presence of anti-RNA polymerase III is particularly associated with a higher risk of scleroderma renal crisis.
Scleroderma renal crisis, that's another emergency, isn't it?
It is. It presents as sudden onset severe hypertension and rapidly declining kidney function. It needs urgent treatment, often with ACE inhibitors. Also, pulmonary hypertension is a major complication in both types, but especially diffuse, presenting as worsening breathlessness, needs specialist investigation and management.
Okay, while we're on antibodies and overlap, let's quickly cover mixed connective tissue disease, MCTD, and Sjogren's syndrome, which we mentioned earlier.
Good idea. MCTD, as the name suggests, has features that overlap between SLE, scleroderma, and polymyositis. The key diagnostic antibody is anti-U1RMP. The ANA is usually positive too.
And Sjogren's, primarily dryness.
Yes, Sjogren's syndrome primarily causes dryness of the eyes, keratoconjunctivitis sicca, and mouth xerostomia due to autoimmune attack on the glands. It's strongly associated with anti-Ro, also called anti-SSA, and anti-LAW, anti-SSB antibodies. These can also be positive in SLE, adding to the overlap confusion sometimes.
Right. Finally, in this section, the inflammatory myopathies, polymyositis and dermatomyositis, both cause muscle weakness, but one has a crucial association we need to act on.
That's right. Both cause proximal muscle weakness, so difficulty getting up from a chair, climbing stairs, lifting arms above the head. Polymyositis is primarily inflammation of the muscles themselves. The associated antibody is often anti-JO1.
Okay. And dermatomyositis, what's different?
Dermatomyositis has the muscle weakness plus characteristic skin features. These include the heliotrope rash, a purplish discoloration around the eyelids, sometimes with swelling, and Gottron's papules, which are raised reddish plaques over the knuckles, and sometimes elbows or knees.
And it's the dermatomyositis that needs urgent cancer screening.
Yes, absolutely critical. Dermatomyositis, particularly when it starts in adulthood, has a strong association with underlying malignancy. It can be a perineoplastic phenomenon.
Okay. What sorts of cancers?
Common associations include lung, ovarian, gastric, colorectal, and lymphoma. So, anyone diagnosed with dermatomyositis needs a thorough, age-appropriate malignancy workup initiated straight away, alongside checking the CK levels, which are usually very high in both conditions, and testing for antibodies like anti-M12, which is specific to dermatomyositis.
Right. That malignancy link is a key takeaway. Okay, let's change track now to probably the most common MSK conditions seen in primary care. Osteoarthritis, OA, diagnosis seems straightforward usually, but the guidance is quite specific about imaging, isn't it?
Yes, very much so. OA is fundamentally a clinical diagnosis based on age, pattern of joint pain, worse with use, better with rest, stiffness, usually short-lived 30 minutes, and reduced function. We should not be routinely x-raying joints just to confirm OA.
When would an x-ray be appropriate then?
If the presentation is atypical, maybe the pain is progressing very rapidly, or there are signs of inflammation like warmth or significant swelling, or if you suspect another diagnosis entirely like inflammatory arthritis or even malignancy, basically if it doesn't quite fit the usual OA picture.
And if you do get an x-ray, what are those classic features? The OLS mnemonic?
That's the one OLS stands for: loss of joint space, cartilage thinning, osteophytes, bony spurs at the joint margins, subchondral sclerosis, increased bone density just below the cartilage, and subchondral cysts, fluid-filled sacs in the bone.
And clinically, in the hands, we differentiate between Bouchard's and Heberden's nodes.
Yes, Heberden's nodes are at the DIP joints, the ones nearest the fingertip. Bouchard's nodes are at the PIP joints, the middle ones. Both are bony swellings characteristic of hand OA.
Okay, management. Nice guidance has shifted things around pharmacologically, hasn't it? What's the current approach?
It has. The absolute core management remains non-drug-based. Education, encouraging exercise, strengthening and aerobic, weight loss if appropriate, and considering aids like walking sticks or braces. That's foundational.
And then the first step pharmacologically.
First line now, specifically for knee and hand OA, is topical NSAIDs, gels or creams. They offer good local relief with much lower risk of systemic side effects compared to oral NSAIDs.
What about paracetamol? Used to be the go-to first oral option.
Not anymore. The evidence suggests paracetamol offers minimal benefit over placebo for chronic OA pain for many people. So it's not routinely recommended first line. You can still use it, perhaps alongside topical treatment, but it's been downgraded.
So if topical NSAIDs and maybe paracetamol aren't enough.
Then you consider oral NSAIDs, or COX-2 inhibitors. But always think about the risks: cardiovascular, renal, GI. And crucially, if you prescribe an oral NSAID COX-2, you should always co-prescribe a PPI for gastric protection, especially in older adults or those with risk factors.
And steroid injections.
Intra-articular steroid injections still have a role, but mainly for managing acute flares of pain and inflammation to provide temporary relief and allow participation in exercise therapy, not really for long-term routine management.
Okay, let's move to bone metabolism. Osteoporosis. Huge issue. Assessment often starts with the FRX tool.
Yes, FRX estimates the 10-year probability of a major osteoporotic fracture and hip fracture. It helps guide decisions. If the risk is low, reassure and give lifestyle advice. If it's high, you generally treat. If it's intermediate, that usually triggers a DEXA scan to measure bone mineral density.
But there are situations where you'd start treatment, usually alendronic acid, regardless of the FRX score, or even without a DEXA. What are those definite indications?
Yes, these are key to know. You'd start treatment if One, someone is over 75 and has already had a fragility fracture. Two, if a DEXA scan shows a T-score of -2.5 or lower, that's the definition of osteoporosis. Three, if the FRAX score indicates high risk anyway. Four, and this is really common in practice, if someone is starting or taking long-term oral steroids specifically, 7.5 milligrams of prednisolone or more daily for 3 months or longer, they need bone protection. And lastly, sometimes if someone's had multiple previous fragility fractures.
Okay. And what about other risk factors, secondary causes that lower bone density?
There are many. Low body mass index, BMI, lifestyle factors like smoking and high alcohol intake, certain medical conditions like rheumatoid arthritis, that's actually the most common secondary cause.
Really, RA itself?
Yes, the inflammation itself contributes to bone loss, plus patients often need steroids. Other causes include endocrine disorders like hyperthyroidism or Cushing's, malabsorption syndromes, and certain drugs besides steroids, think anti-epileptics, SSRIs, aromatase inhibitors used in breast cancer.
So, management starts with alendronate, a bisphosphonate, key counseling points for taking it safely.
Absolutely vital. Alendronate is usually first line, often given with calcium and vitamin D supplements if intake is low. The instructions are strict to minimize esophageal irritation. Take it first thing in the morning on a completely empty stomach with a full glass of plain water, not juice or milk, and the patient must stay fully upright sitting or standing for at least 30 minutes afterwards. No lying down.
Tricky compliance sometimes. What if they can't tolerate alendronate or other oral bisphosphonates like risdronate or ibandronate?
If oral options aren't tolerated, usually due to GI side effects or esophagitis, then the next common step is often denosumab. That's a monoclonal antibody given as a subcutaneous injection every 6 months. Specialist options like zoledronic acid infusions also exist.
Right. Let's touch on two other metabolic bone conditions quickly, osteomalacia and Paget's disease.
Okay. Osteomalacia is defective bone mineralization, essentially soft bones, due to severe vitamin D deficiency. In children, it's called rickets. Suspected in patients with vague, widespread bone pain, muscle weakness, sometimes a waddling gait, or those with risk factors for vit D deficiency like lack of sunlight exposure, certain diets, or malabsorption.
And the blood tests are characteristic.
Yes, typically you see low vitamin D, low calcium, low phosphate, but the body tries to compensate. So you get high parathyroid hormone, PTH, and high alkaline phosphatase, ALP.
Got it. And Paget's disease of bone, what's the classic scenario?
Usually presents in older adults, maybe an elderly man, often asymptomatic and picked up incidentally due to a raised ALP on routine bloods. If symptomatic, it causes localized bone pain, maybe bone deformities like bowed legs, tibia is common, or hearing loss if the skull bones are affected.
And the key lab finding?
The hallmark is a markedly elevated alkaline phosphatase, ALP, often very high, but with normal calcium, phosphate, and PTH. Other bone turnover markers might be raised too. Management, if needed for symptoms or complications, is with potent bisphosphonates like 5-zoledronate or oral risdronate to suppress the excessive bone turnover.
Okay. Lastly, in this section, bone infection, osteomyelitis. The bug depends on the patient context.
It does. In most otherwise healthy individuals, the most common cause is Staphylococcus aureus. However, there's a classic association you must remember. In patients with sickle cell disease, Salmonella species become a much more common cause of osteomyelitis.
Important distinction. And how do we best investigate suspected osteomyelitis?
MRI is the imaging modality of choice. It's much better than X-ray, which can be normal early on, or even bone scans for showing the extent of bone marrow inflammation and any soft tissue collections like abscesses.
And management. It's long, isn't it?
Yes, requires prolonged antibiotic therapy. Often starts with IV antibiotics based on likely organism and sensitivities, if available, then switching to high-dose oral antibiotics. For Staph aureus, typically flucloxacillin or clindamycin if penicillin allergic. The total duration is usually at least 6 weeks, sometimes longer, guided by clinical response and inflammatory markers. Right, before we dive into specific joints like the hip or shoulder, let's just quickly recap those general MSK red flags. The symptoms that should make you pause and think, hang on, is this something more than just mechanical pain? Maybe infection, inflammation, or even malignancy.
Good idea. What are the top ones to keep front of mind?
Okay, think about it. Significant morning stiffness lasting more than 30 minutes suggests inflammation. Pain that is severe at night, enough to wake someone from sleep. Pain that persists even at rest. And then the systemic symptoms. Unexplained fever, unexplained significant weight loss. Any of those need proper investigation.
Definitely. Okay, focusing on back pain now, so common. What are the specific red flags for back pain itself that warrant urgent action, like an MRI or referral?
For back pain, red flags include age being very young, 20 or older, 55 at onset. A history of cancer, thinking about bony metastases, significant trauma preceding the pain, pain that is unrelenting and getting worse, any new or progressive neurological deficit, weakness, numbness, changes in bladder or bowel function, cauda equina syndrome, and again, fever suggesting infection.
Speaking of infection, you mentioned discitis and epidural abscess earlier. How do they present?
Discitis is infection of the intervertebral disc space, often Staph aureus spreading from elsewhere, can cause severe localized back pain. An epidural abscess is infection in the space around the spinal cord. This is a neurological emergency. Typically presents with severe back pain, fever, and rapidly worsening neurological signs like leg weakness or sphincter disturbance, needs urgent MRI, neurosurgical input, and IV antibiotics immediately.
But for the vast majority of patients with simple, nonspecific low back pain, the advice is different.
Absolutely. If it's recent onset, less than 6 weeks, and there are no red flags or neurological signs, the mainstay is reassurance, advice on simple analgesia like NSAIDs or paracetamol, and critically, encouraging them to stay active and avoid bed rest. Movement is good.
And if the pain drags on beyond 6 weeks, or if neurological signs appear,
That's the point where you typically consider imaging, usually an MRI, and referral to physio or potentially spinal specialists, especially if there's evidence of nerve root compression causing radiculopathy.
right, radiculopathy. Knowing the patterns is useful. Can we quickly recap the key lumbosacral nerve roots, L4, L5, S1? What do they do?
Sure, L4 compression typically affects the knee, so you might see weakness of knee extension, quadriceps muscle, and altered sensation over the front of the knee and medial shin.
Okay, L4 knee.
L5 is mainly about the foot and big toe dorsiflexion, lifting the foot and toe upwards. Weakness here causes foot drop. Sensation loss is often over the top of the foot in the big toe region.
L5 foot drop. And S1.
S1 controls plantar flexion, pointing the foot downwards, like standing on tiptoes. Weakness affects the calf muscles. The most reliable clinical sign for S1 radiculopathy is often a reduced or absent ankle jerk reflex. Sensation change is usually on the sole or outer aspect of the foot.
That's a helpful summary. Okay, let's move down to the hip. Huge range of possible diagnoses, very dependent on the patient's age and symptoms.
Definitely. You have to think demographically. For example, severe hip pain and refusal to weight bear in a very young child under 3. You must consider septic arthritis first.
Right. What about slightly older children or teenagers?
Hip pain in a child aged maybe 4 to 8 could be Perthes' disease of vascular necrosis of the femoral head. Hip or knee pain in an adolescent, especially if overweight, think about slipped upper femoral epicysis, SUFE. That's an emergency too.
Okay. What about hip pain in pregnancy?
Pelvic girdle pain, including pubic symphysis dysfunction, is common in pregnancy. Often causes pain around the hips, groin, and back, sometimes with that characteristic waddling gait.
And pain specifically on the outside of the hip, lateral thigh pain.
This needs careful differentiation. Pain directly over the bony prominence, the greater trochanter, often worse lying on that side, suggests trochanteric bursitis or maybe gluteal tendinopathy, sometimes called greater trochanteric pain syndrome. Or it could be iliotibial, IT band syndrome, especially in runners. The key here is usually no pins and needles or numbness.
And if there are pins and needles or numbness on the outer thigh?
Then you should suspect neuralgia paresthetica. That's compression of the lateral femoral cutaneous nerve, purely a sensory nerve. Causes burning, tingling, or numbness on the anterolateral aspect of the thigh, but no muscle weakness. Often linked to the tight clothing, belts, obesity, or pregnancy.
Okay. And if we're examining the hip joint itself, trying to pinpoint pain from inside the joint, like FAI or a labral tear, any useful tests?
2 common provocative tests are FADR and FABR. FADR stands for flexion, adduction, internal rotation. This position tends to impinge structures of the front of the hip and often reproduces pain in femoroacetabular impingement, FAI, or labral tears.
Okay, FADR for anterior impingement, and FABR.
FABR is flexion, abduction, external rotation. This stresses the hip joint differently and can also indicate hip joint pathology or sometimes sacroiliac joint problems. And while examining, always look for weakness, like a Trendelenburg sign, where the pelvis drops on the opposite side when standing on one leg, suggesting weakness of the hip abductor muscles, gluteus medius minimus.
Good points. Quick question on hip replacements. If a patient comes back years later with problems, what's the most common reason for needing a revision?
By far the most common reason for late failure in revision surgery is aseptic loosing, loosening the artificial components gradually loosening from the bone over time without infection.
An acute dislocation, say after a fall, how does a posterior dislocation typically look?
A posterior hip dislocation, which is the most common type, is a surgical emergency. The affected leg usually appears shortened, adducted, pulled inwards, and internally rotated.
Got it. Shortened and internally rotated. Before we leave trauma, let's re-emphasize compartment syndrome. Urgent recognition is key. Those 6 Ps.
Yes, the 6 Ps of compartment syndrome, caused by rising pressure in a muscle compartment cutting off blood flow. They are pain out of proportion to the injury, often the earliest and most important sign, pallor, pale skin, pulselessness, a late and ominous sign, paresthesia, pins and needles numbness, paralysis, weakness and ability to move, and poikilothermia, limb feels cool to touch.
And the management.
Urgent surgical fasciotomy. Time is critical to save the muscle and nerve tissue. Any delay risks permanent damage.
Okay. And we use the Ottawa rules for ankle and knee injuries to decide about x-rays, right? To avoid unnecessary radiation.
Exactly. The Ottawa ankle rules say X-ray if there's pain in the malleolar zone, A and E, either bony tenderness along the back edge or tip of the lateral or medial malleolus, or inability to bear weight immediately, and for 4 steps in clinic.
And the knee rules.
Ottawa knee rules say X-ray if any of these are present. Age 55 or older, isolated tenderness of the patella, tenderness at the head of the fibula, inability to flex the knee to 90 degrees, or inability to bear weight both immediately and for 4 steps. They're pretty sensitive for catching significant fractures.
Great. Helps rationalize imaging. Let's wrap up with just 2 more regional specifics, the elbow and the shoulder's frozen state.
Okay, elbow pain. The common epicondylitis conditions. Lateral epicondylitis is tennis. Elbow pain is reproduced by resisting wrist extension. Medial epicondylitis is golfer's elbow pain on resisted wrist flexion and pronation, turning palm down.
Simple distinction based on resisted movement. And finally, adhesive capsulitis or frozen shoulder. What's the absolute key clinical finding that nails this diagnosis over something like rotator cuff tendonitis?
The hallmark of a true frozen shoulder is a global restriction of movement, but particularly a marked reduction in passive external rotation. The examiner cannot move the patient's arm outwards, even when the patient is relaxed. This restriction of passive movement is much more profound than you typically see with rotator cuff issues alone.
And it has phases, right?
Yes, the classic 3 phases. Phase 1 is painful freezing, phase 2 is stiff or frozen, and phase 3 is thawing or resolution. The whole process can unfortunately take a long time, sometimes up to 2 or 3 years to resolve fully. And remember, the association is more common in people with diabetes, particularly type 1, and thyroid disease. #outro.
Wow, okay. That was a really intensive run through of some seriously high-heeled MSK topics for the AKT and for practice. We've hit on early referral for synovitis, the critical safety checks for DMARDs and biologics, and spotting those crucial red flags.
Absolutely. And remembering those key differentiators, anti-CCP for RA risk, HLA-B27 for the seronegatives, the normal CK in PMR versus the sky-high CK in rash in dermatomyositis, and weaving in those antibodies for MCTD, anti-U1RMP, and Sjogren's, anti-ROLA, helps build that bigger picture.
It really highlights how often what looks like a simple joint problem is connected to something much more complex and systemic.
Exactly. Knowing the facts is one thing, but applying them is key. Like knowing you must screen for malignancy if you diagnose dermatomyositis, or always checking for TB before starting a biologic. It's about connecting the dots.
So thinking about applying this knowledge for you, our listeners.
We talked about how antibodies help differentiate SLE, Sjogren's, MCTD, but there's so much overlap, and the ANA is often positive across the board. So here's something to think about for your own practice. Beyond the basic fatigue, joint pain, maybe dry eyes, what specific clinical features may be worsening your nose, maybe subtle signs of lung involvement like a cough or slight breathlessness, would actually push you to order that more extensive panel, including anti-RO, anti-LOF, and anti-U1RMP, rather than just stopping at the standard SLE screen. How do those evolving symptoms change your diagnostic algorithm? Something to consider next time you face that diagnostic puzzle. Go forth and apply this knowledge.